Hi, I'm Catherine from Arcadia Physiotherapy, and I'm going to give you a whistle-stop tour on prolapse in the pelvic area. So pelvic organ prolapse is often described as a falling out of the organs, so your rectum or your bladder or the uterus coming down within the pelvic space. However, this is quite a scary term, and it doesn't actually necessarily fulfill the right description of what's actually happening. The falling out might be what people are feeling, a sort of heaviness or lowness within their pelvic area. But actually, a pelvic organ prolapse is much more to do with the dynamics of pressure within the whole abdomen. So your sort of diaphragm and ribs downwards, because that is a closed system, obviously, and there are lots of different tensions and pressures that can arise in that area, which then results on an organ maybe being displaced or pushed or pulled out of its normal place, as opposed to just falling out. So it shouldn't, I disagree with people who use the sort of scary terms of falling out, because it's not very helpful and it's not also very accurate. So just to describe why I'm saying what I'm saying, you got within this pelvic area, so we've got the front here, you've got the sacrum and the tailbone, the coccyx at the back, and then these arches of the iliums either side, so the hip bones that you might feel at the front when you're touching your own hips. The pelvic organs sit within this space, and they're all attached towards each other. So they're all connected by fibrous connective tissue and ligaments in some cases, and they're also attached to the inside of this bony area, which gives them quite a good passive support structure. So even if no muscles are contracting or supporting, if you had no pelvic floor muscles at all, they would still be hanging in that space, supported and attached to each other by those ligaments and fibrous tissue. Of course, the pelvic floor muscles, this sort of bowl of muscles around here, do form a part of the support to those organs. But if you have a weak pelvic floor, it doesn't necessarily mean that everything's going to fall out. So there are three main types of prolapse. There's a rectocele, which is where the bowel itself extends and gets stretched and pushes into the back wall of the vagina. So you'll feel a sort of maybe heaviness in the back side of your vaginal opening. It doesn't mean that anything's popping through a gap or anything, but it means that the pressure is building up, and just because the vaginal walls are very elastic, they've got a bit of give to allow that pressure to come through. So often that feels worse when you need to open your bowels, or when you're doing exercise, because the elasticity, the natural happy elasticity of the vaginal wall allows that stretch, basically. The other one, where there's a bladder prolapse, we're looking at the front wall of the vagina. And so if the bladder is tilted backwards or being pushed backwards or downwards, then again, the elasticity of the vaginal wall is going to allow for that a little bit, but you'll feel a heaviness towards the front. That can also mean that the bladder, if it's tilted, means that the urethra, the tube where your urine comes out, can get kinked a little bit, which means that you might be incompletely opening your bladder. So you might sort of stand up after going to the loo and think, oh, I need it again, or you might actually leak as you move off out of the bathroom, because that kink has just straightened up, depending on the position that you're in. The third type is the uterine prolapse, or uterocele, and that is where the uterus itself descends within the vaginal space, or can sort of protrude out depending on the intensity of the prolapse. And that's more to do with the connections of the ligaments of the uterus getting damaged or stretched or whatever. Prolapses do wax and wane, especially with the rectocele, the back passage prolapse, because of the bowels being emptied and then filling up again gradually. So sometimes it might feel worse, sometimes it might feel better. Things like stress, things like level of activity, lack of sleep, nutrition, all these things can affect a rectocele, and to a certain extent other types of prolapse as well. So it's useful, if you suspect you're having a prolapse, or you have, or you know that you've had one for a while, to look at those symptoms and monitor them over a period of time, maybe a week or two, and then you can work out when it's better, and that might enable you to take up some light exercise that you've been missing, and when it's worse, and when you might want to do more relaxing things like yoga, and say inverted postures, or something that doesn't involve gravity or impact or anything like that. So there's lots of ways you can look at your own individual situation and start to make progress without actually having to, to do anything surgical or to do anything with medication at that stage. So what does it feel like? I've mentioned a sort of a dragging sensation, a heaviness, which are both really common, which can, as I say, be related to exercise and activity levels, lifting perhaps. It'll be individual for different people, but these things are typical. I often get asked about whether it's painful. Usually they're not, unless prolapse is to a point where it's starting to come out of the vaginal opening, in which case it might start to chafe on the underwear. Again, this might not happen all the time, but it might be intermittent depending on your level of activity. Intercourse isn't necessarily painful, because remember, this is about soft tissues. It's not about an injury as such. It's not about trauma. It's about a displacement of organs, and they're generally quite soft. Again, you may get soreness if it's protruding or being excessively rubbed, for example, but generally it shouldn't be a problem with intercourse, although obviously you still want to resolve it for your own self-confidence and health and ongoing and so on. What happens if it isn't addressed? Well, lots of these things often are left for a long time, or only discovered after a long time. Obviously, as a physio, we're aiming to improve your situation, reduce the prolapse as much as possible. Sometimes it's possible to reduce it to the point where it just isn't really there. Other times it's more working on the symptoms and management of the prolapse. If it's at a certain stage where, say, stretched tissue is stretched and can't really be sort of tightened up as such, but the symptoms can be brought down to zero and the condition can be managed. If that isn't then addressed, say for a rectocele, for example, where your poo builds up in your rectum and pushes into the back of the vaginal wall, if we're creating an extra sort of pocket in the rectum, then where the stool will sort of sit, if we can't consistently make that come out, then we're talking about irritation of the inner bowel, obviously uncomfortableness for the patient themselves and limiting lifestyle, and creating a dysfunction in the muscles of the pelvic floor. Are they holding on too tight, or are they letting go at the wrong moment and losing the control of that mechanism? So longer term, there are consequences if these things aren't dealt with. Similarly with bladder prolapse. Bladder prolapse might mean in the short term that there's a little leak here and there, maybe on the trampoline or when you cough or sneeze, but leave that for a few decades. And you might well know somebody already who has changed their behavior around their bladder requirements. So if they feel like they're afraid of leaking in public, then they might drink a bit less, but that means they get a bit fuzzy headed and headachy, and their body isn't supported well with good hydration. Their digestion might start to dry up a little bit, meaning harder stools and creating an issue at the back passage. And obviously the embarrassment that goes around continence issues, all of those things can magnify and amplify over a period of time if these things aren't honestly and openly addressed with good education and empowerment as well, because there's lots and lots that people can do at home, such as managing your diet, managing your hydration, doing exercise and keeping moving on a regular basis. All these things actually will help a prolapse and will help manage symptoms and keep you well in yourself, that will make progress towards alleviating those potential longer term risks. Often people ask me about whether surgery is necessary, and sometimes it is. Sometimes people have a prolapse or are really suffering where the prolapse is really protruding from their vaginal opening and they've been having lots of other issues around it. But it's certainly not the first port of call. These things develop over time. These things have multiple factors that affect them. So going straight for surgery often is very distressing, and often it doesn't actually solve the problem, because we need to find out what the cause of the problem is before we can solve it. And that is, there's a lot of consistent themes with prolapses, which I'll talk you through in a moment. But each individual's behaviour is also a part of that issue and a part of the solution as well. So I talked a little bit about where the pelvic organs sit and how they're supported in space. So what could add pressure to that? What could displace an organ or create dysfunction in that area? So if we take a balloon, for example, this is a closed pressure system. It's obviously sealed in and it's got pressure and within it, but it's got some malleability. It can sort of mulch around a bit and move as we do. So if I bent forward, I'm obviously compressing my abdominal space by bringing my ribs down. And if I'm reaching up and standing tall, then obviously that's opening the space, sort of lengthening that area or squishing it down, depending on my movement or position. If we imagine this balloon as our abdominal cavity, at the top we have our diaphragm, and at the bottom we have a pelvic floor. And what should happen is, as our diaphragm contracts and flattens as we breathe in, the pelvic floor should just have a little bit of give to it. So it just expands and gives a little bit as we breathe in. and the whole thing should dynamically move happily to get there. If we don't breathe well, or if we hold our breath during, say, a pelvic floor activity, we're actually compressing that cavity from top and bottom. So we always want to say lift something heavy as we breathe out, because as we breathe out, the diaphragm actually raises up, and that reduces the pressure at the top and allows our pelvic floor to contract and support our core stability, because the pelvic floor is part of our whole core. So breathing is a huge thing. If we're not breathing correctly, because we do it so often, that can add a cumulative pressure over time that restricts the top of the balloon and adds pressure down the bottom. What's soft tissue, if not elastic, malleable? And so things will happily move out of the way or get a bit squished and so on and so forth. But over time, that builds up to become a problem. If we don't breathe with a full breath or very fluidly, that will restrict the top. If we do lots of exercise, or we feel that we need to have our sort of tummy in as ladies, then that will restrict at the front as well. And you can see the tension building in this balloon. Again, that pressure has to go somewhere. And generally in men, it tends to come out in the tummy button where they have an umbilical hernia or a hernia elsewhere. That's where their pressure release has to be. For ladies, it tends to be down the bottom, because we have this vaginal opening that by its nature is elastic and creates space for other organs to move into. Often people have tension in their back, especially if we're sitting a lot at desks. And so you can see if we're restricted breathing at the top, restricted tummy up here, or that could also be not necessarily super tight abs, but sitting in a slump position, reducing that space at the front because our ribs are down, and then tension at the back from stiff muscles, then where is that pressure going to go? This can happen during exercise as well. So I've treated quite a few ladies who hold their breath when they lift heavy weights or when they do a sit up, and they go every time they stand up or lift something or so on. And again, that pressure is going to go downwards and their organs are going to come down. If you have regular constipation, that's going to build up in the bowel, build up in the lower abdomen, again, from the inside, creating pressure that's pushing outwards, and something has to move out of the way for that to accommodate that content of the bowel. If we're then not relaxing our pelvic floor and restricting that exit, that again is going to create stretch and imbalance inside the pelvis. So all these factors over time can build up. Obviously, having a baby creates a lot of a lack of space within the abdominal cavity, and that can cause pressure down on the uterus. But don't forget that we are designed to have babies. There are lots of mechanisms going on with the hormones and the physiology of pregnancy that allows for this to happen. And the pelvic floor itself, although people often sort of say, oh, it's got weak through pregnancy. Well, my view on that is that if I go to the gym and I want to strengthen my muscle, so I add load to it. So over 9 months, what's happening to my pelvic floor? The muscles at the bottom of my pelvis, they're getting loaded again and again and increasingly over a period of time. So the muscles are going to respond by getting stronger, surely. So, and that's because that's how muscles work. We respond to load, our ligaments respond to load and toughen up as we ask them to do more. And pregnancy is a very gradual process. It's not like suddenly we added 2 stone onto somebody in one go. It is something gradual. So what I'm saying there is it doesn't necessarily lead one to the other. You shouldn't necessarily have problems because you've been pregnant. You shouldn't necessarily expect problems because you're having babies. It's individual, and there are often, from my experience, lots of underlying causes or pre-problems that pregnancy doesn't let you get away with. Pregnancy is a big exposer of imbalances in the pelvis and the rest of the body that unfortunately come to the fore when you're under that extra developing shape and size and load. But hopefully that makes sense in terms of the pressure and relieves that feeling of something falling out. What we need to do as physios, and obviously in coherence with you, is to work out where your pressure points are, where this pressure is being created, and how we can relieve that and change habits, change diet, change strength, all that kind of thing, to resolve your particular issue and let that pelvic organ sit back where it was without the added pressure from all these different factors. So what a physio can do, in addition to obviously all that advice and assessing what the problem is, you can do manual therapy. So the pelvic floor muscles are obviously often assumed to be weak when we do treatment on, pelvic floor muscles are often assumed to be weak because there's a problem with them, but often muscles are actually tired because they're over tired and overworked. again, if the diaphragm's pressing down all the time, the pelvic floor is having to counter that to support these organs. So no wonder it's going to get tired after that repeated downward pressure or inward pressure. So a lot of what I do with pelvic organ prolapse is actually creating more space and more elasticity in the pelvis. I often assess people and find that they're very, very tight and stiff and tender inside their pelvic floor muscles. And then creating that space, releasing that manually, can allow for that give and that recoil that the muscles would naturally be doing. And then to synchronize that up, say, with the breathing to make sure that the dynamic starts to resolve. So I can do manual therapy. I can assess, or physios can assess, the actual strength of the muscle, so we can judge whether it actually is weak. And the best protocol for you as an individual is to strengthen up those muscles to get things working better, get things supported better. And I mean, when I say working better, control of the bladder, control of the back passage, because those the muscles around those areas allow sphincter closure, but they also allow things to relax and open. And both those things are equally crucial. It's not just about being short and narrow and tight to hold everything in. We have to let things out, otherwise pressure will build up. We have to allow them out in the way that we are ready and when we are ready, as opposed to scurrying to the toilet every time we feel the urge. We need to get back in control with the bladder, for example. So I can give pelvic floor strengthening advice that's individual to you, because it needs to be individualized. It's not 3 times 10 squeezes 3 times a day. It needs to be more robust and more targeted than that for each individual. And then I said about relaxing and opening the sphincters. Relaxation strategies are super, super important. Prolapse is, as I say, the result of a buildup of pressure in an inappropriate place. And that often can be linked to emotional pressure. I see a lot of emotion around prolapses, a lot of confusion, a lot of fear. And in these COVID times, it's, everyone is under a huge amount of pressure. And that is going to hold in our tension, in our shoulders, in our breathing, in our posture. And all those things can exacerbate symptoms, as well as, the creation of the prolapse in the first place. Lack of exercise, sitting all day as opposed to being able to be out and about, lack of relief from all this emotional pressure. Those things can make a situation feel worse emotionally, as well as, to a certain extent, exacerbate things physically. So I can talk to you about relaxation strategies, mindfulness, physical relaxation to, again, reinstate this happy relationship between the pelvic floor and the diaphragm. So breathing activities that you'll find both calming and will help solve the symptoms as well. So I hope there's just one more thing I want to mention, and that's physical support. So I can also talk to you about pessaries. Now, pessaries in this context are sort of space occupying items, and there's loads and loads of different types. So here's just 3 of them. So this is a ring pessary. This is, if you've been to your GP, this might have been talked about already. It's good for bladder prolapse and uterine prolapse. It's not very helpful for rectocele, the back passage prolapse. And it will sit within your pelvis, sort of tucked in at the front here. I don't know if I can show you that. Tucked in at the front and then angled up towards the back. And it can sit there. If it's fitted well, it can remain there for up to 6 months, where it must be sort of reviewed and reassessed, because you don't want something in there for any longer than that without it being checked and made sure that it's all working as it should. And that supports the bladder neck, so it sort of helps the bladder stay up where it was and keep that urethra lined up so you're not getting the kink. And it also helps to brace upwards and outwards if there's a uterus coming down. But that's just one basic type. Then these 2 work in a similar way. If you think of essentially like a tampon, in that if you pop this into the vaginal opening, it just creates a solid wall. So when things are pushing into it, there's no ability for it to sag downwards. This is sort of bracing things upwards and outwards. And they come in different types and sizes. But these ones you can remove and put in as and when. So there's lots of ladies use a pessary just when they're exercising, because that's the only time that they feel that there's an issue. And then they can pop it out again and resume their normal life. So there's lots of things to help like that. And I can discuss that with an individual if that's something that we think might be useful. So I hope that's been helpful. If you've got any questions, please post below and I'll try and answer them as best I can. I'm Catherine Peden. I'm in Nottingham at Arcadia Physiotherapy.